Hello and welcome to my lecture on hepatitis C. My name is Lars and I'm a senior researcher at CHIP, the Center of Excellence for Health, Immunity and Infections in the Infectious Diseases Department at Rigshospitalet in Copenhagen, Denmark. This lecture will consist of 3 parts. It is estimated that around 2.3 million HIV-infected individuals are co-infected with hepatitis C virus or HIV worldwide. Because HIV and hepatitis viruses are similarly transmitted, co-infection is not uncommon. This map shows an overview of the prevalence in different regions of the world. Because of the high prevalence, it is important to know why and how to manage HIV and HIV co-infection. The prevalence varies according to the predominant mode of HIV transmission. In Northern Europe and other regions where sex between men is the predominant mode of HIV transmission and access to HIV and HIV preventive strategies for drug users are common, the prevalence of hepatitis C virus co-infection is relatively low, between 5% and 25%. However, in Eastern Europe, where injection drug use is the main driver of the HIV epidemic, rates of co-infections are greater than 50%. In sub-Saharan Africa, HIV is mainly transmitted through heterosexual sex from mother to child, and the prevalence of HIV co-infection among HIV-positive people is consequently low. The overall prevalence is 5.7%, ranging from 4.6% in Southeast region and up to 7% in the Central and West regions. Since injection drug use is uncommon in sub-Saharan Africa, the dominant mode of HIV transmission seems to be iatrogenic through use of unsterilized medical equipment. In South and Southeast Asia, the prevalence varies between countries and risk groups sampled, ranging from 5% or less in unselected HIV-positive persons from India and Thailand, up to 18% in China and more than 40% in Nepal. Prior to the availability of effective HIV therapy, studies have found the median life expectancy to be up to 20 years shorter in co-infected patients compared with HIV monoinfected patients. The excess mortality among HIV co-infected patients is only partly due to hepatitis C, but also due to multiple other competing risk factors for early death, such as drug and alcohol abuse, smoking, and poor adherence to medicine. Since HIV infection in most people is a slowly evolving infection where complications usually take decades to develop, the relative importance of liver-related death in the co-infected population is determined by the age composition, access to effective HIV therapy, and the prevalence of competing risk factors. Data from the large pan-European Eurociter study showed that among co-infected patients followed in the period from 2000 to 2012, AIDS was still the most common cause of death at 24%, followed by liver-related death at 22%. Overall, the incidence of liver-related death in Europe has been decreasing in the period from 2000 to 2012, but while Western Europe has seen a decline in liver-related death of 16% per year, the incidence has remained stable in Eastern Europe. Although cohort studies of HIV-treated co-infected patients have confirmed that a sustained virologic response lowers the risk of all-cause and liver-related mortality, the uptake and efficacy of HIV therapy prior to the introduction of direct-acting antivirals have been too low to have any major clinical impact at the population level. In Western Europe, half of the reduction in liver-related death can be explained by improvements of CD4 cell counts over time and enrollment of new patients with less fibrosis into the cohort. The incidence of liver-related death is expected to decrease further across Europe when broad access to DAAs has exerted its long-term impact. Let's discuss now the risk factors for liver-related death. These factors, which are associated with progression of fibrosis and liver-related death in the HIV monoinfected patients, also apply to co-infected patients and include severity of fibrosis stage at presentation, age, male gender, alcohol, obesity, diabetes, and co-infection with hepatitis B. Many studies have shown that HIV co-infection accelerates the progression of fibrosis compared with HIV monoinfection. This is particularly seen in patients with a CD4 cell count less than 200 cells per microliter. Some, but not all studies have found an association between HIV viral replication and risk of HIV-related liver disease. Older studies have found an association between exposure to some antiretroviral drugs and increased risk of liver-related death, but have not been confirmed in newer studies of patients receiving more contemporary, less hepatotoxic antiretroviral drugs. Some, but not all studies have shown that genotype 3 infection accelerates progression of fibrosis. After reviewing the epidemiology of HIV co-infection, we will now focus on how to manage and diagnose the co-infected patient. In the guideline published by the World Health Organization WHO and the European AIDS Clinical Society, or EACS, it is recommended that all HIV-infected patients are tested for anti-HIV at the time of diagnosis and annually hereafter. If the antibody test is positive, it should be followed by an HIV RNA test to document chronic or cleared infection. Chronic HIV infection is defined by HIV RNA positivity for more than 6 months. Staging of liver fibrosis in chronically HIV-infected patients should be performed at the time of diagnosis by elastography or other non-invasive test and annually hereafter if the HIV infection is not cured. In resource-limited settings, the guidelines from the WHO suggest that the aminotransferase platelet ratio index, or APRI, or the FIB4 test should be used for the assessment of hepatic fibrosis rather than other non-invasive tests that require more resources. Patients with cirrhosis are at risk of hepatocellular carcinoma and should therefore, according to the EACS guidelines, undergo 6-monthly hepatic ultrasound. Screening for esophageal varices should be done at the time of diagnosis and at 3 to 4 year intervals thereafter if varices are not present initially. For further details, please review the section on management of cirrhosis. The WHO guidelines recommend 6 monthly ultrasound examinations and/or alpha-fetoprotein estimation and endoscopy every 1 to 2 years to exclude esophageal varices. In patients negative for anti-HAV or anti-HBs, vaccination against hepatitis A or B is recommended. This is the end of part 1 of this lecture. I will begin part 2 by discussing direct-acting antivirals or DAAs.